Hi friends, welcome back to BGS Clinics. In practice, we come across three different scenarios: a so-called clinical case, an acutely severely injured patient, and an operated case. Clinical assessment in all the three is different from each other. In this class, I will discuss clinical assessment of the operated patient. The purpose of taking history of and examining the operated patient is not to diagnose a disease that was already done, for which the patient got operated as well. The purpose now is to detect post-op complications and see if the patient is making recovery or not. What do you mean by complication? In simple words, anything that goes wrong is a complication. It means an untoward or adverse event leading to morbidity or mortality. Basically, because of a disease and subsequently in the perioperative period, some of the physiological functions come to a halt, often partially and sometimes totally, or the systems function abnormally. By recovery, we mean regaining of the physiological functions back to normal. Clinical assessment of hospitalized patients, including those who underwent a surgical operation, goes by the acronym SOAP, SO, which stands for Subjective Assessment, Objective Assessment, Conclusion of the Assessment, and Plan of Further Management and Documentation of Problem, if any. Subjective assessment means history taking. Objective assessment means physical examination and evaluation of clinical charts and reports of investigations. Let us first see how to interrogate the operated patient. But before that, please note that I have done a comprehensive discussion in this video. All the points may not be applicable in every case that you assess. You should use discretion. These are the points which you are supposed to ask: pain, fever, breathing, bladder, bowel, feeding, drainage or soakage, and specific. Now let us discuss these points in detail. Ask for pain at three sites: at the site of operation and around, in the legs, and in the chest. Why at these specific sites? At the site of operation and around, to get an idea if the wound is developing any complication such as hematoma, infection, or breakdown. Normally, after any trauma, surgery included, wound is painful for the initial 3 days. Subsequently, the pain should lessen and disappear. Persistence of or increase in pain after 3 days suggests development of a complication. Ask for pain in the legs for deep vein thrombosis and in the chest for cardiopulmonary complications such as cardiac ischemia, pulmonary embolism, and pneumonia. If fever is present, then ask for the degree and if associated with rigors. Rigors suggest more extreme swings in temperature and more serious infection. Mild fever during the initial 1 or 2 days may result from normal physiological response to the trauma of surgery. Please do not immediately commence antibiotic treatment as a knee-jerk reaction. A higher degree of fever commencing after a day or two and which is rather persistent suggests some complication. The post-op day on which fever commences might give you a clue to the cause. In the early post-op period, keep atelectasis in mind as a possible cause of fever other than physiological response. During intermediate period, fever may result from pneumonia, urinary tract infection, thrombophlebitis at the site of intravenous access, or any other simmering complication. Fever developing late in the post-op period is caused by infection either in the wound or a deep-seated location. Possible causes of difficulty in breathing in the form of shortness of breath, or and cough are pulmonary embolism, collapse, or consolidation. Especially 4 to 5 hours after the operation, ask if the patient passed urine satisfactorily. If not, the patient may complain of a great discomfort with an intense desire to pass urine but is unable to do so. This may be associated with frequent dribbling or passage of only small volumes of urine. This symptom complex suggests retention of urine. Patients find it difficult to initiate micturition due to pain, strange or unfamiliar surroundings, and possibly the effect of anesthesia and drugs. Compulsion to pass urine in an unusual position, that is, lying down or sitting in bed, also contributes to the problem. I will discuss later the examination findings in retention and how to treat it. If patient was already catheterized in the operating room, then note the output and color of urine to judge if patient is being adequately hydrated or not. Ask if patient passed stools or flatus at least. This is more relevant in patients who have undergone a laparotomy or laparoscopy. Passage of stools or flatus is one of the indications of recovery from paralytic ileus. Diarrhea and/or passage of mucus indicates either pseudomembranous colitis or development of a pelvic abscess. Pseudomembranous colitis is a side effect of antibiotics like ampicillin, amoxicillin, etc. Good appetite and patient eating well suggests that health is generally good. A patient who is not tolerating feeds will generally complain of nausea or maybe even vomiting. Try to find out the cause. Sometimes it may be drug-induced. For example, metronidazole, even when administered intravenously, can cause gastritis. If patient was not eating due to paralytic ileus, then ask if she or he has started feeling hungry. Return of hunger is a good sign suggesting recovery from paralytic ileus. What is the difference between hunger and appetite? Hunger is physiological. It occurs because of biological changes throughout the body which signal that one needs to eat to maintain energy levels. Appetite is simply the desire to eat which may surge even if one may not be hungry. Taking this history is obviously not applicable if a nasogastric tube is in place. In that case, you need to do a quantitative and qualitative assessment of the nasogastric tube aspirate, particularly if it is bilious or otherwise. On many occasions, one or more drains, often tubular, are left in the operative area or inside an anatomical tube or an organ to let out the blood, bile, lymph, or any other body fluid. This is a PVC tube drain left in peritoneal cavity after a laparotomy. This is a tube drain left in at a mastectomy. These are tube drains left in after excising multiple fibroadenomas from both breasts. This is a tube drain left under the flaps at above knee amputation. Sometimes a corrugated drain is left in. This is a corrugated drain made up of PVC, and this one is made up of rubber and available in sheets. A piece of desired size is cut out of it. The outer end of a corrugated drain needs to be covered with one or more absorbing pads, and in that case our interest is to know how many pads get soaked in a day. In different situations, we have different expectations from drains in terms of the amount and the physical and sometimes chemical and biological nature of the effluent. Practically, in hospitalized patients, we get these details from the nursing notes. In patients who have been discharged from hospital with a drain in place, We get this information directly from the patients when they come back to outpatient department for follow-up. And finally ask for symptoms specifically applicable to the case based on the index pathology, the kind of operation performed, and the expected outcome. And then go for objective examination, which includes physical examination of the patient, examination of tubes, drains, lines, catheters, and evaluation of various clinical charts maintained and reports of any investigation if performed. Physical examination is carried out in an orderly manner, general followed by systemic followed by local. This order is slightly different from the one followed in examination of the so-called clinical case. In the clinical case, the order is general followed by local followed by systemic. In the operated patient, it is practically convenient to conduct local examination and then examination of tubes, drains, lines, and catheters at the end. For this part of examination, you need to organize a dressing trolley, sometimes a pedestal lamp as well for good illumination, and donning of disinfected gloves. This systematic method sails you smoothly through the conduct of physical examination. Clinical methods for general examination are more or less the same which I have discussed in my videos on general examination. You may revisit those videos. Here I will discuss the points which are specifically relevant to the post-operative status. Now that does not mean that the remaining points are not relevant, but I have already discussed them in the videos on general examination, and they carry the same significance here as well in terms of clinical methods, interpretation, and inference. So I won't repeat them here. Drowsiness in the immediate post-op period can result from the effect of a general anesthetic or a sedative. Persistent drowsiness, however, is a bad sign, and the possible causes are an excessive dose of a sedative, any serious life-threatening complication, or fluid electrolyte imbalance. A patient who is bedridden may be either systemically sick or locoregionally disabled due to either the index pathology or surgery. If a locoregional disability is ruled out, then assess the patient carefully and investigate if necessary to find out the systemic problem. A patient who is up and about and ambulatory is a good sign. After general anesthesia, patients may remain confused for a couple of hours. In elderly, confusional state may persist much longer. Does the patient appear in distress? A reason for distress could be pain, anxiety, or a respiratory problem. Now we proceed to systemic examination, particularly examination of respiratory system and abdomen. The purpose of examination of respiratory system is to look for collapse and consolidation, and for that carefully examine the air entry, breath sounds, and adventitious sounds. Collapse of a lung tissue results from obstruction of airflow in a main stem bronchus by a plug of mucus. These are the clinical features of collapse. Vocal fremitus is usually absent. Dull percussion note is felt overlying the airless area. Breath sounds are usually absent and no adventitious sounds are heard. Filling of alveoli with fluid results in what is called consolidation. This may result from either pulmonary edema or pneumonia, and these are the clinical features found overlying the involved area. Vocal fremitus is increased, dull note is felt on percussion, breath sounds are of bronchial type, and late inspiratory crackles are heard. So these are the differences in clinical findings between collapse and consolidation. Vocal fremitus is usually absent in collapse, whereas it is increased in consolidation. Breath sounds are usually absent in collapse, whereas bronchial breath sounds are heard in consolidation. No adventitious sounds are heard in collapse, whereas late inspiratory crackles are heard in consolidation. Examine the abdomen, especially for distension and retention of urine, particularly following operations in the lower abdomen, including groin and the perineum. This patient developed retention of urine following circumcision. Visible fullness, tender lump, and dull percussion note in suprapubic region suggest retention of urine. However, please note a pitfall. Practically, tenderness cannot be considered a differential point because the operative area nearby will also be tender anyway. In short, the classic picture of retention is not always necessarily present, so it can be a little tricky to diagnose the condition clinically. How will you manage post-op retention of urine? First and foremost, do not harass the patient by repeated questioning of whether he passed urine or not. The patient is already in distress and irritated. Instead, believe the patient if reliable and reassure him. Make sure that adequate analgesia has been provided. Give a hot water bag fomentation on the lower abdomen. Recently, I heard that cold water bag fomentation also works, but I really don't know. I haven't tried it so far. If patient can't or is not permitted to go to bathroom, then provide privacy with curtains applied all round the bed. If patient can walk down to bathroom, give him enough time there. Leave a tap in the bathroom open to allow a constant gentle flow of water. This simple measure often reflexly stimulates micturition. It is always worth waiting for the patient to pass urine naturally. If all the conservative measures have failed, then catheterize the bladder, either in and out or indwelling, depending on the anticipated duration of the need. In young patients, in and out with an infant feeding tube or a simple rubber catheter may suffice. But in an older patient, indwelling catheter for a couple of days may be a better option to avoid recurrent retention and repeated catheterization. And then proceed with local examination, that is, examination of the site of operation and around. The clinical methods for this will vary according to the case. They should be discussed actually on case-to-case basis. What about examination of the wound per se? Well, wound infection in the form of say cellulitis or abscess manifests only from third or fourth postoperative day onwards and not before that. Moreover, the risk of developing wound infection in a so-called clean case is less than 2%. So, there is no point in changing a dressing in a clean case for the initial 3 or 4 days after surgery unless you are suspecting some other complication like development of a hematoma or gaping of the wound. By the way, how do you classify operative wounds? Clean, clean contaminated, contaminated, and dirty. I leave the exercise for you to find out the criteria with the possible risk of infection developing in them. Then examine the tubes, drains, lines, and catheters, if any, and look for problems associated with them. Are they patent or else got blocked? Have they become loose? Have they partially come out? Learn how to actually manage these problems on the field on case to case basis. As far as an IV line is concerned, look at two things. If intravenous fluids have been prescribed, then is the appropriate pint at prescribed drip rate going on? And secondly, Look if thrombophlebitis has developed in the concerned vein. Elongated, cord-like red warm swelling along a vein suggests thrombophlebitis. Thrombophlebitis means inflammation of the intimal layer of a vein and is commonly caused by irritation by intravenous fluids or drugs. Lower limb veins are more prone to develop thrombophlebitis. It is usually aseptic, but can be septic if aseptic precautions were not observed while taking an IV line or changing IV fluids or giving injections. I do have a couple of photos of thrombophlebitis, but I am not sharing them here because somehow the characteristic features are not seen so convincingly in photos. Then go through the charts such as vitals, weight, fluid balance, commonly called intake-output, urine or blood sugar chart in a diabetic patient, neuro observation chart in a patient who has undergone cranial surgery, and so on. And then go through the reports of investigation if done. Compare them with the previous reports. And this is how you conclude your clinical assessment at that point of time. Is the patient hemodynamically stable? A patient whose vital parameters have been within normal limits during the period of observation is declared hemodynamically stable. Any complication developing? Here, by complication I mean any complication other than the one which can result in hemodynamic instability. Is the normal function of organ systems recovering? For example, recovery from paralytic ileus after a laparotomy or laparoscopy, recovery of consciousness after intracranial operation, and so on. Then document the plan of action, if any, for the next day or later. For example, remove a drain on so and so date, any investigation to be done on so and so date, discharge on so and so date, etc. Document any problem that is likely to come in the way of further management. For example, if you need a certain investigation which is a bit expensive and if the patient is not affording, or the machine in your hospital is out of order, or decision by the patient or relative is pending, or whatever, then mention so in the case sheet. So that's it about clinical assessment of the operated patient. Thanks for watching.